Good morning, everybody. Welcome to UCSD Department of Medicine Grand Rounds. We have the great pleasure this morning of hearing from two of our internal medicine residents. They were two of the 4 finalists selected from our resident research symposium, where over 40 residents presented their work. First, it's my pleasure to introduce Dr. Melissa LeRoux. Dr. LeRoux is a second-year resident here at UCSD's Internal Medicine Residency Program. She completed her Bachelor of Science degree here at UCSD, majoring in biochemistry and cell biology, graduating summa cum laude and with Earl Warren College honors. She then completed a Master's of Science, also here at UCSD, in biology, where her master's thesis focused on the circadian rhythm amplitude and neuronal survival. She then pursued her MD degree at The Ohio State University College of Medicine, and we were really fortunate to recruit her here to UCSD for her internal medicine residency training. As I mentioned, she was one of 4 residents selected as a finalist from our resident research symposium at the end of April, and she's also the recipient of the SIGM National Young Scholar in General Internal Medicine recognition. Dr. LeRoux will be presenting today on the effect of glucagon receptor antagonism on ketogenesis in SGLT2 treated subjects with type 1 diabetes. Dr. LeRoux, thank you.
Thank you so much for that lovely and thoughtful introduction, Dr. Jassel. Hi, everyone. My name is Melissa. It's really an honor to be here, and I'm very excited to tell you about the research project that I worked on with my awesome research mentors, Dr. Jeremy Pettis and Dr. Schaefer-Bader. They're both endocrinologists here at UCSD who specialize in type 1 diabetes. And the clinical trial I worked on involved looking at the effect of glucagon receptor antagonism on ketogenesis in SGLT2 treated subjects with type 1 diabetes. So before I jump in, I just wanted to outline what I'll be talking about for the next 5 to 10 minutes, which is the background for the project. I'll first talk broadly about type 1 diabetes and highlight the need for additional therapies. I'll then introduce the SGLT2 inhibitors as a potential therapy for the disease and discuss some barriers to use in this patient population. I'll then talk about the pathophysiology of DKA, which is the major barrier, and introduce the idea of using the glucagon receptor antagonist to help mitigate this risk. And then finally, I'll introduce the major hypothesis for the project. So as we all know, type 1 diabetes is an autoimmune disease which leads to destruction of the beta cells of the pancreas, which causes patients to be dependent on the insulin that we give them for survival. And there are actually only a few drug classes available to treat type 1 diabetes, which are the insulins and then the almost never used amylin analogs. And only 20% of patients achieve the A1C goal, which is set by the ADA of less than 7% to best avoid micro and macrovascular complications like cardiovascular disease and kidney disease. And this means that 4 out of 5 patients are not meeting the goal, which in my opinion is really bad. And it clearly highlights the need for additional therapies that would improve glycemic control and reduce risk of morbidity and mortality from the disease. So we are all aware that SGLT2 inhibitors have had great success in the management of type 2 diabetes. They've also had great success in non-diabetes conditions like heart failure and chronic kidney disease. They've really kind of proven to be wonder drugs over the last few years. And they've actually been studied in type 1 diabetes as well. So there have been a few randomized controlled trials with the SGLT2 inhibitors, sotagliflozin and empagliflozin, which have demonstrated significant reductions in A1C, blood pressure, weight, and time in glycemic target range. Unfortunately, they have also been shown to increase the risk for DKA, which has been the major barrier to FDA approval and then use in this patient population. And the risk is pretty significant. So trials have demonstrated a increased relative risk of between 5 and 17-fold. And this is pretty unfortunate given the benefits of the drug, especially with cardiac and renal protection, which we know these patients are at very high risk for. So one of the questions leading to our major hypothesis was, how can we safely use these drugs in type 1 diabetes, or how can we unlock these drugs for this patient population so that they can also reap the benefits of the drug? And I think to answer this question, we really need to take a look at the pathophysiology of DKA. DKA occurs when the balance of insulin and kind of regulatory hormones like glucagon is upset. So glucagon promotes ketogenesis. It increases free fatty acid production and conversion of these free fatty acids to ketones. It also releases glucose from the liver. And insulin has the opposite action of glucagon. So it inhibits free fatty acid formation and promotes glucose utilization by the cells. And type 1 diabetes is actually thought to be a state of too much glucagon, in addition to what we know as kind of a state of insulin deficiency. And this is actually thought to be because the insulin that we give them does not reach the same levels in the islet cells as kind of normal physiologic insulin release from the beta cells, which would travel to the alpha cells and kind of suppress glucagon secretion. So that physiology does not occur with the insulin we give these patients. And it's actually, some endocrinologists think that this hyperglucagonemia is pretty central to the pathophysiology of type 1 diabetes. And this glucagon hypersecretion drives both hyperglycemia and ketosis in the disease. So how do SGLT2s promote DKA? So there have been a few proposed mechanisms which are illustrated here by this figure that I stole off of Twitter. But the first is that when SGLT2s are combined with insulin, it's often necessary to decrease the insulin dose. And this lower dose of insulin just may be insufficient to suppress lipolysis and ketogenesis. The SGLT2 receptors have also been found to be expressed on alpha cells, and the SGLT2 inhibitors may actually just promote glucagon secretion, which would kind of in turn promote ketogenesis. And then finally, the SGLT2 inhibitors may promote urinary reabsorption of ketone bodies, which would lead to decreased secretion and again drive metabolism towards ketogenesis. So given the background that I have just shared, in theory, glucagon receptor antagonists could improve glycemia and reduce ketone formation and risk of DKA. And glucagon receptor antagonists have actually been studied in type 1 and 2 diabetes. There's actually more data in type 2 diabetes. So there have been multiple large phase 2 studies with multiple glucagon receptor antagonists that have demonstrated a dose-dependent lowering of fasting blood glucose and A1C. The data in type 1 diabetes is a bit more limited, but actually a lot of the research is coming out of here at UCSD in my research mentor, Dr. Pettis's lab. So their group found that with the GRA REMD 477, and this was in a trial with 21 patients, that a single dose led to decreased insulin requirements and improved glycemic control. There's actually a phase 2 randomized control trial in process right now. The treatment period was longer, so 12 weeks, and the number of patients was higher at 75 patients, and they've actually demonstrated similar results, and it's in the process of publication right now. So getting onto the hypothesis for our project, we theorized that by using glucagon receptor antagonists with SGLT2 inhibitors, patients would benefit from both therapies with regards to glycemic control, but also be protected from the risk of DKA seen with the SGLT2 inhibitors alone. So shifting gears to talk about the project, I'll first explain our study design. I'll explain the insulin withdrawal challenge, which was a major method for the study. I'll then present the major results from the study. I'll discuss some major conclusions that we drew from the study. And then finally, I'll highlight some strengths and weaknesses and suggest some future directions for study. As far as our study design, so this was a randomized double-blind crossover study, and it included 12 subjects, all of whom had type 1 diabetes, and all of whom used insulin pumps and continuous glucose monitors. This allowed easy analysis for analysis of insulin use and glycemic control. And for those of you who are not familiar with continuous glucose monitors, I've included a sample report here. So you can see that the report here is over about 2 weeks, and the report gives you like the time in target range. It gives you the time at which, or the percent at which someone was in the high range, percent in the low range. And then it also gives you more advanced data like the average glucose at each time point over the day. So subjects were randomized 1-to-1 to group A or group B, which I'll get to in the next slide. But the drugs we used were the SGLT2 inhibitor, dapagliflozin, 10 milligrams daily, and then the glucagon receptor antagonist, the human monoclonal REMD-477, which was 70 milligrams subcutaneous weekly. So after enrollment in the trial, the patients underwent baseline studies, which included collecting continuous glucose monitor data and insulin use data. They then underwent an insulin withdrawal study, which I'll talk about in the next slide. They were then randomized to group A or group B, and group A received the SGLT2 inhibitor plus the glucagon receptor antagonist. Group B received the SGLT2 inhibitor plus a placebo. They underwent therapy for 4 weeks, and then the baseline studies were repeated. There was then a washout period of 6 weeks, after which the groups crossed over to the opposite treatment arm and then received another 4 weeks of therapy, and then the baseline studies were again repeated. As far as the insulin withdrawal challenge, so essentially the patient's insulin pumps were discontinued for 8 hours, and this was to induce a state of no insulin and a state of ketogenesis. BHB, or beta hydroxybutyrate, and glucose levels were measured every 30 minutes throughout the length of the challenge, and then the study was actually stopped if the BHB level rose above 3 millimoles per liter, the glucose level above 400 milligrams per deciliter, or if the subjects were just unable to tolerate the study. And we looked at peak BHB concentrations and also the length of the withdrawal challenge. And then we also designed something called the Ketogenesis Index, which was essentially designed to provide a measure of rate of ketone formation over time. And this was calculated. And I've included an example result from a withdrawal challenge from one of the patients in the trial. So you can see here that the beta hydroxybutyrate levels on the y-axis, time is on the x-axis, and the study was stopped at 5 hours due to the BHB being 3. As far as the patient population that we had, so I mentioned there were 12 subjects in this trial. The mean age was 41 years. There were slightly more females than males. This was an all Caucasian study. The average BMI was 25.7. The length of their diagnosis was 27.7 years, and then their baseline A1C was 6.6%. Importantly, all subjects completed the trial without any significant adverse effects. So moving on to our results. So this graph is a visual summary of the insulin withdrawal challenge results. So you can see it's a plot of the mean ketone level over time during the withdrawal challenge. There's ketone level on the y-axis, time of withdrawal on the x-axis, and then the lines represent the different groups. So you can see here that throughout all the time points, the SGLT2 group stays above the combination group. Putting that graph into numbers, we found that during the insulin withdrawal challenge, the maximum ketone level was lower in the combination treatment group than the SGLT2 group, so 1.94 versus 2.44. We also found that the duration of the challenge was longer in the combination treatment group than the SGLT2 group, so 442 minutes versus 364 minutes. We found that the ketogenesis index was lower in the combination treatment group than the SGLT2 group, so 44.5 versus 73.1. And these results were all statistically significant. We also found that the average continuous glucose monitor glucose level was lower in the SGLT2 and combination groups than the baseline group. So the baseline had an average of 150 milligrams per deciliter, the SGLT2 group 139, and the combination group 130. And this 20 milligram per deciliter drop between the baseline and the combination treatment group corresponds to an A1C improvement of about like 1.2%. The results didn't quite reach significance, but they were very close. We found that the time in the target glucose range, which is 70 to 180 milligrams per deciliter, was higher in the SGLT2 and combination group than the baseline group, but again, it didn't quite reach statistical significance, although it was very close. So the baseline group was in range 70% of the time, the SGLT2 group 77%, and then the combination treatment group 84%. And for reference, the American Diabetes Association targets 70% for this number. Importantly, the time in the hypoglycemic range was similar between all 3 groups, and there were no symptomatic events during this trial. We also found that the average total daily insulin use was lower in the SGLT2 and the combination groups than the baseline group. So at baseline, they use 41 units of insulin per day, with the SGLT2 inhibitor alone 37 units per day, and then the combination treatment of they use 30.7 units. And this result was statistically significant. So to summarize our data, so we found that the combination of a glucagon receptor antagonist and the SGLT2 inhibitor resulted in reduced ketogenesis, a decreased average glucose level by around 30 milligrams per deciliter, which corresponds to an A1C improvement of 1.2%. We found an increased time in target glucose range by around 14% from baseline without an increase in hypoglycemic events. And then we also found that they had a lower insulin dose from around 25% from baseline. So we think our data suggests that the combination the glucagon receptor antagonist and the SGLT2 inhibitor may be a way to improve clinical outcomes in type 1 diabetes with respect to glycemic control, but also maximize patient safety with respect to risk of DKA. So just going into a few strengths and limitations of our trial. So the strengths were that it was a randomized double-blind trial. Another strength, but that was that all subjects completed the trial, so there was no missing data. And then our crossover design allowed for match controls. A few limitations. I think the biggest limitation with it was that this was a very small and homogeneous patient population. So it was an all Caucasian study. And then the average A1C was, before at baseline was less than 7%, which is quite different from in general, what we see with type 1 diabetics. This is more of a function of the trial design, but with any crossover design, there is a potential for carryover effects between the two groups, but the washout period is introduced to try to mitigate that risk. So I think our results from this trial are very exciting and interesting. With regards to the trial, I'm basically just showing the key results of my focus of the project, but we as a team definitely have more data to analyze. As the secondary analysis, we're looking at the drug's effect on performance markers of cardiovascular disease risk. We're even looking at endothelial function. So there's definitely more work to do with this trial, and our target journal eventually would be Diabetes Care. With respect to glucagon receptor antagonist therapy for type 1 diabetes, so again, I think our results with this drug are very exciting, but these drugs are still in development currently. I mentioned this earlier in my presentation, but the drugs have shown good promise as far as improving glycemia and reducing insulin use in phase 1 and phase 2 trials. I believe a phase 3 trial was recently approved, so they're definitely on the right path for approval. I think a question to look into is whether these drugs can be used alone to prevent DKA. So, I mean, even without the use of the SGLT2 inhibitor, the rates of DKA are quite high in type 1 diabetes. So I think this would be something, very interesting to look into. With respect to SGLT2s, their use in type 1 diabetes, so I think with our trial, we've demonstrated they can be used safely with glucagon receptor antagonists. But I think another interesting idea would be to look at the safety of using them with continuous ketone monitors. So when we prescribe SGLT2 inhibitors, we often give them intermittent ketone monitors for them to use when they kind of feel ill to check for signs of ketosis. But they're actually continuous ketone monitors being developed that would be kind of a bundle with continuous glucose monitors, which in theory could warn patients of signs of DKA in real time. So, looking at whether these drugs could be used safely with this new technology, I think would be pretty interesting. So that's actually all I have for you guys. I'd like to thank everyone for listening. I'd also like to thank Dr. Jassel and the internal medicine program for this great opportunity. And then finally, I'd like to thank my research mentors, Dr. Jeremy Pettis and Dr. Schaefer Bader for all, and also the rest of the research team for all their help and support over the last year. It's been super great to be involved with this project. And with that, I can take any questions that you guys have.
Dr. LeRoux, thank you for that thought-provoking and really impressive presentation. I am just really incredibly impressed by what you were able to accomplish during your research block, and this is really very interesting work. Dr. LeRoux's presentation is now open for questions. We have a question from Dr. Rubin. He says, ketone bodies have been viewed as being potentially cardioprotective in patients treated with SGLT2 antagonists. Do you think that combination therapy outlined in this exciting study may decrease this effect?
Yeah, well, that's a very interesting thought. I don't know if I know the answer to that question, but I think, you know, it's something that would be worth looking into. I think, I mean, we are looking at kind of peripheral markers of cardiovascular disease in this trial. We still need to analyze that data. So I think, you know, those would be very interesting results to look into.
Dr. LeRoux, I am not very familiar with the continuous ketone monitors. Can you tell us a little bit more about how those work? I think most of us are familiar with the continuous glucose monitors. Is it a separate device that patients have to wear, or can it be incorporated into some of the continuous glucose monitors?
Yeah, so essentially, these are still in development currently, but the idea would be to have, it would be the same device, like the continuous glucose monitor and the continuous ketone monitor, kind of as one device, if that makes sense. So it would be very easy for the patients to use.
That sounds amazing. Sounds like a great way for patients with type 1 diabetes to identify DKA early, whether related to SGLT2 inhibitors or otherwise. Any other questions? Okay, from Dr. Baxi. There was one patient who was 65 years old. Was he or she the one with the duration of TID, type 1 diabetes for 52 years?
I don't know if I know the question that answer off the top of my head, but I would imagine that would be the case. Yeah, I mean, I think that would be the case, but I don't know the answer off the top of my head.
And Dr. Baxi says, wow, that is impressive. Dr. LeRoux, thank you again for that terrific presentation. We really look forward to your continued work in this important area.
All right, thank you.
Terrific. Now, if we could just have you stop sharing, and we will have Dr. Sykes share her presentation. Perfect. Excellent. Next, it's my pleasure to introduce Dr. Alex Sykes. Dr. Sykes received her Bachelor of Arts degree in Hispanic Studies from Texas A&M University in College Station, Texas, where she also pursued her Doctor of Medicine degree, graduating as a member of the Gold Humanism Honors Society. We were very fortunate to recruit Dr. Sykes to UCSD for her internal medicine residency training, and she's currently one of our third-year residents. Dr. Sykes has been a member of our Resident as Clinician Educator track, and she was actually selected as a finalist from the Research Symposium, both for her research presentation as well as for her Resident as Clinician Educator project. But we are only having her present this project at Grand Rounds today. Dr. Sykes will be one of our chief residents in quality and safety at the VA San Diego, beginning in July. She'll be speaking to us today on her research on the association of breast arterial calcification with coronary artery disease in women. Thank you, Dr. Sykes.
Thank you so much, Dr. Jassel. I honestly am so honored to be here and present this exciting research. You'll have to excuse me, I have a little bit of a sore throat, but not COVID. I've been tested 3 times. So if I cough intermittently, that's why. But Like Dr. Jassel mentioned, my presentation is on the association of breast arterial calcification with coronary artery disease in women. To get started, I'd like to share that both my mentors, Dr. Lori Daniels and Dr. Quan Bui, are both consultants for a local San Diego biotech company, which is called CureMetrics. You'll be hearing more about this company later on, but wanted to share that. I myself have no personal disclosures. My research is focused in preventative cardiology, and we're asked in grand rounds to share something personal, which is easy to do with my topic today. Unfortunately, my family has had personal experience with early cardiac death, but it's through the support and love for each other that we have survived. Here are those women in my life who have always cared for, encouraged, and inspired me, and the reason that together we have not just survived, but thrived. In the middle is my mom, on the left my Aunt Casey, Aunt Susan, and on the right is my Aunt Margie, and here below are some of my many cousins. I come from a long line of strong Texas women, and it's because of them that I am where I am. This research is for them and for women like them, and aims to find new ways to reduce cardiovascular risk, especially in women like my women, so they can continue being their great selves. So without further ado, I'd like to get started discussing my presentation. Despite modern advances, incredible new technology, and innovative approaches to cardiac care, cardiovascular disease remains the #1 cause of death in women. 35% of deaths in women worldwide are from cardiovascular disease. In 2019, 275 million women were diagnosed with cardiovascular disease and 9 million died. Now, the rates for cardiovascular disease in men are thankfully declining. However, in women, they're continuing to be on the rise. So you may ask, why is this the case? There are several proposed mechanisms for continued high burden of morbidity and mortality, and some of the most common are listed here. Cardiovascular disease in women is understudied, as women are often underrepresented in clinical trials. It's undertreated, including in secondary prevention. Post-heart attack mortality and reinfarction rates are higher among women compared with men. It's underdiagnosed, as women have higher rates of subclinical coronary artery disease and are subject often to lower accuracy with traditional imaging studies, including exercise tests and MIBI. And most relevant to our discussion today, these women are under-recognized and thus miss opportunities for early prevention for cardiac disease. In order to recognize women, we need good screening tools. Our current screening tools, like the ASCVD risk estimator, Framingham risk equation, and pooled cohort equation, are used to identify patients at higher risk for cardiovascular disease and implement early prevention. However, these approaches incompletely estimate both the presence and the burden of atherosclerotic disease, leading to potential undertreatment of large population of women. We need better tools. In effort to improve risk assessment calculators, attention has turned to coronary artery calcium. Coronary artery calcium, also known as CAC, detectable on CT scan, is a highly specific feature of coronary atherosclerosis. On the basis of single center, multi-center, population-based studies, both in the short term and the long term, with outcomes data for over 15 years at this point, CAC scoring has emerged as a widely available, consistent, and reproducible means for assessing risk for cardiovascular outcomes. A key feature is that it's especially useful in asymptomatic patients for planning of primary prevention. Thus, CAC scoring through CT scan has become an effective, non-invasive risk stratification tool. To highlight the clinical utility, I adopted this figure from the ACC/AHA guidelines, demonstrating how CAC can either up-classify or down-classify a patient's risk profile. So going through this figure, at the top row, you can see that a patient was given an ASCVD risk score. The scores range from less than 5% to above 20. And each of these is a category that's clinically significant because it determines whether the patient needs to be on a statin. For example, the low category, it's not recommended that the patient be started on a statin. And the highest category, greater than 20% ASCVD risk, yes, they should be on a statin. However, these middle categories are divided. The middle low says to consider a statin, middle high says yes to start a patient on a statin. Now, if we add the ASCVD risk score with for additional data of coronary artery calcium, it's actually shown that it can improve our ability to classify these patients. So if you have an ASCVD score, but a CAC score of 0, you notice that the patients in this low middle group who we were considering statin, it no longer do those patients need a statin. And if the CAC score is 0, additionally in the middle high group, they also do not need a statin. So sort of summarizing this, the low and the high groups, you're not going to notice a change with CAC. However, it's these middle categories of patients that we will see an adjustment in the clinical guidelines. So unfortunately, although it's a good study, CAC is obtained, coronary artery calcium is obtained via CT scan, which is expensive and involves radiation exposure to our patients. Leaves us thinking, what else can we consider? As it turns out, mammogram may be a promising alternative for risk assessment. Mammogram is readily available in all healthcare settings. Routine screening mammogram is already recommended for breast cancer screening in all women as early as age 40 and definitely by age 50 based on USPSTF guidelines. Annually, mammograms are performed over 39 million times. So this is a lot of data to contend with, and we need to find out how we can use it. So how mammograms work. Mammogram works by detecting clusters and patterns of calcifications in the breast parenchyma. Some of these clusters can represent precancerous or malignant cells, which is why it's used for breast cancer screening. But similar calcifications, if they're organized in a linear fashion, represent breast arterial calcification, which is featured here in these panels. You can see it demonstrated to varying degrees. On the leftmost panel, this is an example of mild breast arterial calcification. Again, you see that linear deposition in the intermediate range in the middle figure. And on the right side, you can see this marked presence of breast arterial calcification. And this is sort of a classic description that's called a tram track-like appearance that is seen in more severe back or breast arterial calcification. Radiologists have observed this phenomenon for many years, but it wasn't until 1980 that the first clinical study was published by Baum and colleagues associating this finding with diabetes mellitus, which opened the doors for future study. Now, one key thing I want to highlight is the difference between coronary artery calcium and breast artery calcium. This figure is going to assist me doing that, but the leftmost circle you can see here is a representation of a coronary artery, and on the right here is a breast artery. And so in coronary artery, the calcium deposits in the media of the vessel. That's what we think of when we talk about the pathophysiology of atherosclerotic plaque. But in the breast artery, we see that the calcium is depositing mainly in the media of the vessel. And it's thought that because of this distribution, BAC may contribute to vascular and myocardial pathology through an inflammatory process and might represent an early marker for vascular stiffness and endothelial dysfunction. Overall, this is to say that breast artery calcification is different from pathology that occurs in coronary arteries, but is a finding which may present even earlier than coronary calcium and signify future cardiovascular disease. Since its initial discovery, there have been several studies that show a strong association between BAC, breast arterial calcification, and CAC, coronary artery calcium. These studies are listed here. As you can see, all have a high statistical significance. Notably, the most recent study by Yoon and colleagues showed that presence and severity of breast arterial calcification was significantly associated with the risk of subclinical coronary artery disease in asymptomatic women, which highlights its potential benefit for prevention strategies. Here I'm highlighting that a major challenge in these studies is how they went about describing breast artery calcification. Most of the studies use a distinguisher of present versus absent, which relies on individual radiologist interpretation, which can be subject to inter-reader variability. But even in the more advanced semi-quantitative studies, as you can see in the Moradi, Marjolie's, and then Yoon studies, there's challenges that are present with a semi-quantitative analysis. For example, in the Yoon study published in 2018, in order to get a representation of breast artery calcification, they used mammograms were reviewed by a specialized breast radiologist who had to have at least 8 years of experience. He or she was then blinded to the clinical information and retrospectively reviewed the mammograms with a specialized monitoring system. He or she calculated the number the length, the density, and gave a score for each of those values, then added the scores together, and a total BAC score, breast artery calcium score, was divided into 3 categories, 3 grades. None, which was a total score of 0, mild, a total score of 1 to 6, and severe, a total score of 7 to 12. Then the process was repeated, and a second reader went through the exact same process to account for inter-observer variability. Overall, it's a quite complicated process. So altogether, although the prior studies established a relationship, they were limited by their subjective and qualitative assessment of breast artery calcium. This leaves area for improvement, opportunity for improvement in studies that could provide automated quantification for assessment of breast artery calcium, which leads me to our study. Based on the background I've just discussed, we sought to assess the association between breast artery calcium and coronary artery calcium in a subpopulation of women that are likely to be just the ones who are missed in risk stratification tools. So we asked, in women without known atherosclerotic cardiovascular disease, is breast artery calcification associated with coronary artery calcium? The purpose in this design is that these women without ASCVD diagnosis already would be women who are not already identified as high risk, women who would not be identified for early cardiovascular disease prevention, and thus would remain at potential risk for future bad outcomes. Moving into our methods, we pulled data from all UCSD women between the years of 2016 and 2018 who had both a mammogram and a coronary CT scan within 1 year of each other. To say a different way, women were excluded if they did not have a mammogram or if they did not have a CT thorax, or the images were greater than a year apart from each other. This left us with 278 women in the initial group. Then the presence of atherosclerotic cardiovascular disease and other risk factors were determined via review of medical records through September 2018. Atherosclerotic cardiovascular disease, ASCVD, was considered present if patient had a history of heart attack, peripheral artery disease, stroke, prior stent, and carotid artery disease, or carotid artery disease. All women with a baseline diagnosis of ASCVD were excluded, resulting in a final study population of 225 women. Unlike prior studies, who were only able to quantify BAC as present or absent, or at best semi-quantitatively, we have an advantage of calculating a BAC score. We partnered with a local San Diego-based biotech company called CureMetrics, whose logo is featured here. And CureMetrics has created an automated intelligence computer-aided design that interprets mammograms and calculates a specific value for the amount of breast artery calcium present in each. This value has been given the name Bradley score. And this AI tool allows highly accurate and precise measurements of BAC as compared to binary measurements or crude estimations of mild, moderate, and severe. This tool was incorporated into our methods. So the presence of BAC on mammogram was defined as a Bradley score using the technology from CureMetrics. And the presence of coronary artery calcification was present as an Agatston score greater than 0 on coronary CT scan, which is standard of practice based on prior CAC studies. Some baseline characteristics of our patients. The mean age of our patients is 61 years old. Mean systolic blood pressure is 126 millimeters of mercury. Mean ejection fraction was 57.5%, and the mean CAC score was 79. 48% of our patients had hyperlipidemia, 21% of our patients had diabetes, 28% are current or former smokers, and 48% had hypertension. Using logistic regression, we studied the relationship between Bradley score and the presence or absence of coronary artery calcium. We found that for each standard deviation increase in BAC, women were 2 times as likely to have coronary artery calcium. But you may think, okay, this might be related to their possible confounding variables, the fact that they have these other comorbid conditions. But we analyzed the data again, adjusting for age, hypertension, diabetes, lipid concentrations, GFR, and smoking status, and found that our association was maintained. Women were still almost twice as likely to have coronary artery calcium for each standard deviation increase in BAC. Both of these analyses were highly statistically significant. course, some limitations of our study is the size of the study. We had just over 200 women. It's older data. The data was initially pulled from 2016 to 2018. And because of our statistical analysis, we used CAC as a present versus absent variable rather than for the quantification. But a summary takeaway from our study is that even in patients without atherosclerotic cardiovascular disease, breast artery calcium is independently associated with the presence of coronary artery calcium. Although I'm excited about these research results, and I think that was an extremely important slide, I think that this slide here is my most important slide. What happens now? We now know that based on our and prior studies, breast artery calcium is associated with coronary artery calcium, which can be a predictive factor for future cardiovascular disease. But what should we do as clinicians? What do you do if you get this information and you're looking your patient in clinic in the eye? What do you say to them? We think that this should at least prompt a patient-provider discussion regarding the prevention of cardiovascular disease. You should consider a referral for further risk assessment with a specialist versus doing that in clinic visits at the time of getting this data back. And then using breast artery calcium as, in a sense, a picture worth 1,000 words for cardiovascular risk assessment by either yourself or a specialist. There are multiple studies in the realm of coronary artery calcium and coronary CT scans that have shown that having a concrete evidence of coronary artery disease, like positive CAC on a study, improves adherence to both medical therapy as well as lifestyle modifications. So this conversation is of high clinical utility. Here's a figure depicting what we anticipate back presence, how we anticipate back presence being used clinically. So here is our patient. She comes to you. She just got a notification that she had breast artery calcium present on her scan. You discuss that that has potential risk stratification implications for her future in cardiovascular disease. And then that can prompt discussion about what her current lifestyle looks like. What is her diet? What is exercise that she performs weekly? The possibility that she might be a candidate for targeted medical therapies and may have been missed for other opportunities until this moment. And can also prompt you to think, you know, is this a patient that I should have this initial discussion with? And otherwise, she was thought young and healthy, and maybe we'll follow up annually. Instead, you might transition to a more frequent follow-up with medical providers to continue those discussions and continue checking in on her cardiovascular risk. And overall, the ideal outcome is that we would decrease cardiovascular disease mortality. So now some future directions of our study. These are the next questions our research group is asking and looking to answer, as well as other research groups throughout the country. Does the presence of breast artery calcium predict future cardiovascular events? How does the prevalence of BAC change with age? Is BAC equally predictive of outcomes in younger and older women? Do women without many or even any cardiovascular disease risk factors still have BAC? And if so, is it still predictive of outcomes? When and how should we get radiologists to begin reporting back on mammograms? And what should we have that report say? But now some updates in BAC. So when I was first, let's see, can I get rid of this? When I was first presenting this research at a conference, it was right after this study had come out. So this is a study from Circulation Cardiovascular Imaging that came out in March of 2022, just recently. And it was a cohort study of just over 5,000 women aged 60 to 79 who were recruited after mammogram screening between October 2012 and February 2015 in North Carolina. It's interesting because BAC in their study was determined both present versus absent, like some of the prior studies, but also quantified using densitometry scanner actually at UC Irvine. So in their study, after an average follow-up of 6.5 years, these postmenopausal women with breast artery calcium were found to have statistically significant higher rates of stroke, atherosclerotic cardiovascular disease, cardiomyopathy, peripheral artery disease, global cardiovascular disease, and cardiovascular related death than those without breast artery calcium. So this is one of the biggest outcomes data studies that has come out this year. sorry if my tablet is getting in the way, but this is now some data from our research group that is yet unpublished data. So I want to make that qualification, but we're aiming to publish it this year at the next AHA conference. And this is an association of breast artery calcium with all-cause mortality separated by age group. So as we're continuing to pursue these questions, we found some very interesting results. So on each of these figures is representative of a different age group. So on the far left is women age 40 to 59, in the middle age 60 to 69, and then on the far right side is age 70 and up. Our data is now data, we've expanded the women we have access to, so it's over 14,000 women. And we are seeing a similar trend for back as we just did in the prior study, which that it is associated with mortality. However, we are seeing an interesting, important distinction based on age group. So in our most recent data, breast artery calcium was detectable in 6% of women age 40 to 59, this cohort, 23% of women age 60 to 69, and 52% of women over the age of 70. Over a mean follow-up of 4.2 years, there were more deaths in women overall with back compared with those without back breast artery calcium. But most interesting of all, when cohorts are separated by age group, the presence of back was associated most significantly with mortality in the younger women. So that's here in this in each of these three figures. The red line in the diagram represents women who have back present, breast artery calcium present, and the green is women without back. On the x-axis, it's follow-up time over years, and then the survival probability is on the y-axis. So you can see that there in each of these figures is a split with survival probability. However, that split is most pronounced in these younger women, and that is statistically significant. So in these younger 40 to 59-year-old women, we're seeing that the presence of back does have important predictive impact. So these are exactly the women that we want to identify to start early prevention strategies and maximize heart healthy lives. In summary, breast artery calcium is visible and quantifiable using routine mammography. Breast artery calcium is associated with coronary artery calcium and may be a risk-enhancing factor for cardiovascular disease. If breast artery calcium is present, consider discussions about cardiovascular disease prevention and stay tuned for more research in this promising arena. Thank you so much for your attention. Thank you for this opportunity to present at Grand Rounds. I feel very honored, but a most special thank you to both my mentors, Dr. Lori Daniels and Dr. Kwan Bui, who have allowed me to participate in this research and mentored me along the way. Thank you to Dr. Atul Malhotra, Dr. Jana Raffleson, and Dr. Simran Jassal, who all sat with me and helped prepare for a Grand Rounds type presentation. And also thank you to the CureMetrics group, Homa, Nora, and the entire research group who's doing amazing work and very interesting things with automated technology in order to get this mammogram information. Thank you.
Dr. Sykes, thank you so much for this thought-provoking presentation. Very interesting work. From Dr. Parker, we have a few questions. Are the radiologists aware of your data, and are they always calling mild back when seen on mammograms? And then a follow-up question, does CAC or BAC improve with preventive medicine or medication? Are adjuvant hormone therapies, such as aromatase inhibitors, increase cardiovascular disease events? It would be of interest to review serial mammograms in this population to study potential impact of preventative counseling. And she said, happy to discuss offline.
I absolutely would love to discuss this offline because I also think it's fascinating. And then especially like you're mentioning, could these not just be a marker to prompt that initial discussion, but could this be something that serially we can utilize with clinical benefit? I don't have an answer to most of the second questions, so I need to investigate further myself. But I would, I think one thing is in the coronary CT world, we know that as women get older, and even in some of the data that we show here, just the presence of breast artery calcium alone is present at a high rate as women age. And so it would make sense that it would become less clinically useful to serially monitor as women get older, but I'm very interested by that. And then the first part of the question about the radiologists, actually this data initially was sort of discovered within the radiology literature, and then cardiovascular research sort of moved it into the more clinical sphere moving forward. So the radiologists are aware, and it's institution-based how they're reporting. When I was talking with Dr. Jassel, it sounds like at one point the radiologists at the VA were reporting this on routine mammogram. The institution that I trained at in Houston for medical school has it, they have sort of a text that's their blanket text if there's any present. So kind of could even be in the mild range. And so, you know, I kind of alluded to this, but just to state it explicitly, I think this is such powerful information. We have millions of studies every year, and we really just don't know how to utilize it best. And so that's why I'm excited that this is something I hope to continue pursuing and is being pursued at our institution. And hopefully we can continue to be thought leaders in this space and help guide that transition from having this data to partnership with the radiologists and creation of really, you know, great opportunities for clinical value in the future.
Excellent. Thank you, Dr. Sykes. And then a comment from Dr. Gass. CAC scores only confer risk of ASCVD. Patients with high ones are not treated as a form of prevention. Thus, the back CAC correlation may not correlate with actual ASCVD. Any further comments?
I don't have a further comment for that, but I appreciate that and need to reflect on that somewhere. Thank you, Dr. Gass.
And he says he posed this question just prior to this slide with the up arrow showing ASCVD, and that he was most intrigued by this slide showing mortality outcomes by age. Are there any further questions? As a primary care doctor, I am really intrigued by the idea of mammography serving as a screening tool for two of the major causes of death for women. So I think that this could be really game-changing. Thank you so much to both Dr. Sykes and Dr. LeRoux. I'm so proud of you and all of our residents who've participated in the research block. I think it's incredibly impressive what you all have been able to accomplish. And I want to congratulate all of you and thank your mentors for supporting you and guiding you through these terrific opportunities. I want to thank all of you for joining us for Department of Medicine Grand Rounds today. And please join us next week for our last Department of Medicine Grand Rounds for this academic year. I want to remind you that when we resume Medicine Grand Rounds in September, it will be held in a new time slot from noon to 12:50. We will be having hybrid sessions depending on the status of COVID, where we may have some sessions that will also be both in person as well as via Zoom. Stay tuned for more information. Next week's presentation will be at the usual time slot at 7:30 on Wednesday. Thank you very much. Have a great day.